Peritonitis, what diet we cut down here? Fat. What did I said in liver cirrhosis patient? What do we cut down? Protein. Make sure highlight that word. And when we said no steak, remember? Hepatic encephalopathy. I'm repeating few words here, then I will move on, but we must know good wording. Patient has liver cirrhosis, and if they give you a question, I said patient has ascites, and patient is admitted with edema. What do you cut down here? Salt and the fluid. Are we clear? Patient has encephalopathy and neuropathy. What does it mean? You're monitoring level of consciousness. What do you cut down the diet here? Protein. What is high here? Ammonia level. Ammonia level is high. And what do you cut down totally here? If you think as a picture, they have ascites, they're bleeding, and their ammonia level is high. So what do we cut down here? The protein, the salt, and the fluid. So those are very good. Everyone is okay. Make sure you guys highlight the word encephalopathy. And I said neuropathy, where you have acetaxis and flapping tremor. They're bleeding. And diet is very important. Your question may be on diet. And what diet do you cut down here? The protein. When they use the word ascites, edema, then you pay attention, salt and water. Now, next is, what do we do for when they have ascites? I will be talking in the procedure. They remove the fluid from the stomach, and we call the word is paracentesis. And I will be talking in the next, all the procedures, a little bit on the next section. But let's finish the med-surg, but everyone should know. When patient has neuropathy and encephalopathy, you're cutting down the protein. But remember, your liver detoxified all the medication. So two organs are important. If they're bad, you cannot give a lot of medication, kidneys and liver. Liver is bad, what do you monitoring? Hepatotoxicity. If they have word hepatotoxic, you cannot give a lot of medication. And so they got to cut down their medication because they're not going throughout the body. Everyone is okay. I said gallbladder is on the right side, pancreas is on, gallbladder is on which side? We said on the right where the liver you have, and pancreas you will go and cut down the diet on both of them is the fat. And remember, pancreas, any question on there, you monitor blood sugar because your insulin comes from there. I will move on cholecystitis, we said, diet fat, and I said pancreatitis pain is on the left side. And what do you cut down here? Pancreatic enzyme you give them, and you give them is cut down the diet is the fat. What is pancreatic enzyme? How do you give them? With food, because it helps them in digestion of food. And because you're restricting fat, always add in your question, fat soluble vitamin. A, D, E, K is your fat soluble vitamin. Whenever you have problem in digestion of fat, you are missing your vitamins which are absorbing with the fat. So what are the fat soluble vitamins are? A, D, E, K. Now I will move on the next thing is cholecystitis we did. Number 6, hepatoencephalopathy. Number 7, appendicitis. Where is the appendixes? On the right lower quadrant. So your liver is on the right side and your appendix is on the right side. What is the word is called McBurney point. Where is the McBurney point is? Right here, the umbilical and right iliac crest. So remember, the appendix is on the right side. So iliac crest is your bone and McBurney point is right lower quadrant. In exam, they start even asking the position. Where would you assess? So remember, you assess between right iliac and umbilicus area. So on the right lower part, you will show in the picture, that's the area you're assessing for pain. Now when patient has appendicitis, do not apply the heat. And what is the complication of appendicitis? What is the complication can be? It can rupture. And what does it call? Peritonitis. I will write down the word peritonitis. So peritonitis is the pain, and after pain, patient, if it ruptures, and when does it rupture? If you apply the heat. That's why no heat application, no enema, nothing by mouth. Patients should go to the hospital and they have to do the surgery for appendicitis. So everyone, what is the complication of appendicitis? Peritonitis. What do you monitor patient who is admitted with appendicitis? I want you to write down the word complete blood test, CBC, and there is infection. What would you see? White blood count is high. So because there's infection, so peritonitis is complication. What do you assess in lab would be your white blood count is high. So write down the word CBC, the blood test is called CBC, but what would be high? CBC means red blood cell, white blood cell, everything you're looking, but what would be high here is important, white blood cell. No heat application, and what does the patient goes here? Surgery, appendectomy. After appendectomy, what do you monitor your patient here? Is number one, position. Appendectomy position after surgery is semi-Fowler's, or they can turn on the right side. Turn on the right side. So you can write it turn on the right side or semi-Fowler's position. I will be talking about in different sections, the things we use for patient are the drain. And what is one of the drain they apply here is called Penrose drain. And Penrose drain, after surgery, patient come back, Penrose drain. They are like a small tube. But remember, all the fluid need to drain out. I will be talking about Jackson Pratt. I'm sure you guys have heard, Hemovac. And one of them is Penrose drain, because they have a very small incision, and they put those tubing here and monitoring for the drainage. Once there is no drainage, they remove those Penrose drain. And if patient has Penrose drain, question, position is good to put your patient on semi-Fowler. So everyone, appendectomy, CBC is important. And what is rebound tenderness? Sign of appendicitis. No enema, nothing by mouth. And patient should be in the hospital, position after surgery, Fowler's, semi-Fowler's, or turn them on the right side. Pinworm question, common in the children, pinworm. And underline the word, how do you diagnose them? These are the worm. Second line, tape. Tape is applied or tongue blade covered with the tape to the anal area. Your answer would be putting a tape to the anal area, and here you can collect the pinworm egg early in the morning. And next line, so second line, tape is important. Third line, you can put on the anal area, and you're collecting the egg. Next line, to prevent from scratching, and the last line is cutting the fingernail because they are scratching. Now, next is on after the pinworm, you guys, just few things is important here. Then GI, you have patients who have problem in swallowing, like a stroke patient, and dysphagia question. How do we already talked about dysphagia? I will have you the main line highlight. Who do evaluate your patient for speech problem and swallowing? Underline the word speech therapist. So patient cannot swallow. Who will assess them? A speech therapist, and it's called consult speech therapy. Occupational therapy, OT. OT helps them also to feed. Third line, position. When patient has problem with dysphagia, sitting upright. And when they swallow on third line, chin should be flexed slightly. So in your third line is on that is highlight, allow adequate time, but on the top you have head upright position, slightly flexed, and encourage patient to eat and swallow. Allow adequate time, don't be in rush, let them take their own time. And also, last two line is oral hygiene is important, and you guys already highlighted the word for the cancer of the esophagus, and we already added earlier alcohol and tobacco. So you can highlight that, but everyone should know feeding problem. Can you assign UAP to feed her or CNA patient when they have dysphagia? No, it should be, the patient should be fed by licensed person. Are we clear? Patient had a stroke, 10 years ago, no question, dysphagia, but they said patient had a stroke, patient has dysphagia, how do you feed them? Licensed nurse, or maybe your speech therapist and OT, but they don't feed forever, and they will pass it on to the nursing. So, and I want you to keep in the room is what? Suction. Any question on dysphagia? Suction should be available. Number 10 is on your page number 34, gastric tube feeding. On tube feeding, questions are, number 1, first line, semi-foulers. And which one you have semi-foulers? I want you to write down continuous feeding. What is the meaning continuous feeding? By pump. When you are giving by pump, your position is semi-foulers to prevent aspiration. Assess, second line, on next is distension. Check the stomach for distension. Then you will go on in the last third line or the fourth line at the end. Because they can aspirate, your question would be respiration, lung sound. If you feel congested, maybe they aspirated. Aspiration of food and fluid can cause is the distension, coughing and choking on page number 35. So main thing I want, we all know the tube feeding patient. But we all remember, we raise the head of the bed. Continuous feeding, you will pick up the answer, semi-foulers. And why do we raise the head? To prevent aspiration. What do you assess here? Lung sound. Because if they aspirate, they're going to be congested. Next page, if you have a question, patient is fed by tube feeding, and patient is coughing, and patient is spitting, white fluid coming out in their cough. What do you do? So I want you first thing highlight the word cough, choking, respiration, and frothy sputum. Watch for white frothy sputum. Watch for cough instruction. In your question, patient is coughing, patient spitting, the white sputum. What do you do? What do you do? What would you do if you think patient has aspirated? First thing, stop the feeding. That's your answer. So what do you assess? You stop the feeding. Who does the tube feeding by patient or by LVM? Who does the TPN? Who does the TPN? RN. Difference between TPN and IV pump is beeping. Any question? Pump is beeping and your IV and TPN is not going. What do you do as a nurse? Don't turn it off, because this should be turned it off by RN. What do you do? Assess for kink. Check the position. Why? Maybe it's kink. Maybe there's a position. You can fix it, but do not touch the pump. Same thing. You have feeding. Can CNA should turn off the pump? No. It only should be LVN who can assess and turn the pump off. So remember, there are questions like that. And you got to read it. So I'm just showing you how your question, we all know tube feeding, but what is it important? We are assessing here aspiration. Patient just keep on coughing and spitting the white sputum. What do you do? Stop the feeding. Then you assess, call the doctor, whatever, or remove the tube. But first thing, you don't want more feeding to go into the lungs. So watch for frothy sputum. Highlight that one. Then third line, check the placement of the tube feeding. And how do you check the placement? How do we check the placement? Is by listening the lung sound. You put the air and you can hear the sound and you aspirate. And what do we do here? Check the pH. Some question may be pH of the stomach. You have in the fourth line pH, I want you to write down there, normal pH from the stomach is 4. Below 4 is okay. If you have 6 and 7, that means the tube is not in the stomach. So 4 pH is good, and you're monitoring for is patient that they have is right place, placement. When do you check the placement? Before you give feeding, before you give medication? You may get question on that. When do you check placement of your tube? Before you give feeding, before you give medication? And the last line is continuously, then what do you do? Withhold the feeding. And what is the word is called, you're checking is called the word, I want you to add there the word residual. What is the word residual? You aspirate and correct there 100 or more than 100, you hold the feeding. Less than 100, you continue the feeding. Everyone is all right? So what do we check? Residual. So you guys know, highlight that word. And where do you keep the patient formula? Room temperature. All your tube feeding, room temperature. TPN must be kept in the fridge. It should be kept in the fridge. But your tube feeding should be kept in the room temperature. What is it important here? To check the expiration date. If you have a question, number 11, bolus feeding. What is the meaning bolus feeding? You're giving more feeding. You're giving through the syringe or maybe open bag, and you're giving 300 cc every 8 hours. So what is a continuous feeding? By pump. What is a bolus feeding? When you feed through the tube or you're giving maybe an open bag and you're giving a lot of feeding. So what is the bolus feeding? Larger amount you're feeding in one time. What position do you put on bolus feeding? I want you to write down is Fowler's position. Why? Because you're feeding a lot of formula in one time and stomach is full and they can aspirate. So this position, bolus feeding, is your position is Fowler's. Continuous feeding, your position would be semi-Fowler's. Everyone should know the word residual. Everyone should know checking for aspiration. Any frothy sputum, you stop the feeding right away. And you check the placement. Then you go on number 12. Continuous feeding means by drip, hourly basis. That means you're giving by the pump. And that's all you need to know. Position we all need to know is semi-Fowler's and Fowler's. Continuous feeding, you have Fowler's, semi-Fowler's. Bolus, you have Fowler's position. What are the complications of your patient who has tube feeding and you're feeding them on number 13? Two important ones. I want you to highlight diarrhea and aspiration. Diarrhea and aspiration is important, and I want you to be sure on your tube feeding question in nursing care. What is important? If you say your patient is totally on continuous feeding and NPO, what is your nursing priority? And what would you plan for your patient care? When they use this word planning of patient care, they're asking care plan. What do you do if patient is on tube feeding and nothing taken by mouth? What is your priority here? Anybody? What is your priority for tube feeder who's not feeding by mouth? Very good. Mouth care. And how frequently do we do the mouth care? Every 2 hours. So make sure what is your priority here? Frequent oral hygiene. So remember that wording. And next page we'll move on. And last line on this continuation with the feeding is clamp for 30 minutes after giving medication. Another question. You are a nurse and you're giving patient your medication through the tube, and they may word it, your NG tube is also connected with suction. Whether it's connected with suction or not suction, what do you do after you give medication? Don't attach the feeding right away. What do? Clamp it. Why? Absorbing the time of medication. And what happens if you read it, if they're saying suction, what will happen? You give medication, suction will take it out. Patient is not taking anything by mouth, but we are only giving medication, and you give medication, you attach with the suction, the medications have not been absorbed. So what do you do after you feed the patient? Leave it and let them suction. How frequently do you change your tubing on tube feeders? How frequently do we change the tubing? All the tubing must be changed once in every 24 hours. Everyone is okay? Once in there. All the tubing, we must change it and must be labeled, because that's our responsibility for contamination. You bag those bags, they can run even more than 24 hours, but we must spike the tubing every 24 hours. So, few questions we all should know, we are nurses, and these are the kind of questions we can see. So we have done a little bit on GI, liver cirrhosis. Let me revise diet. What diet we give them? Protein, we cut down. In gallbladder and pancreas, what do we cut down here? Fat. So keep that in mind. Encephalopathy is liver cirrhosis, I said. Now I will move on your renal. In renal is acute renal failure. But before I go on renal failure, first thing I want to ask you a few questions here. If you get a question for incontinency, you have a lot of incontinent patients. What do you do for incontinent patients? You're working and you have a lot of incontinent patients. What do? Use diapers? No. Foley catheter? Kegel exercise. What is another answer? Bladder training. So make sure we all know that wording, because we are nurses. They're not very hard questions. Bladder training. And number 2, Kegel exercise. Those are good answers. Now, UTI. How do you prevent UTI? UTI is nosocomial infection. How do we prevent UTI?
Wipe from back to front.
Yes, very good. Cleaning your patient from front to back. We all have learned anterior to posterior. What else can help them to prevent UTI?
Increase fluid.
Fluids are always good. Fluid answer, yes. Taking them to the bathroom. Not holding the urine for longer time. Must go. I know a lot of time we can drive in freeway 4-6 hours without going, but it's not good. If you feel you have to go and your bladder is full, how long you keep the urine in there, risk for infection. So going to the restroom, taking your patient every 2 hours, bladder training would be good. So what would be more you're looking on UTI questions are? Cleaning is important. Fluid is important. Cleaning, very important. Perineal care is very important, right? So hygiene, maintaining the hygiene for your patient. What are the signs of UTI? What are the signs of UTI? Frequency of urination, burning sensation, and
Confusion.
very good. Confusion in older patient. Remember, older patients' sign of infection are confusion. They cannot say much. They're just laying, and all of a sudden you see the level of consciousness, infection. And so, what is sign of UTI in older patient? Confusion. But person who is alert, oriented, what is the first sign you feel? You already said burning, frequency, and patient has Foley catheter. How do you know they have UTI? The urine is very cloudy, thick urine, sediments in the urine. And very important thing is hematuria. When you see the blood in the urine, that is sign of UTI. So remember, don't miss that. Yes, frequency is good and all that sign, hematuria. Sign of UTI. What do you do if your patient has UTI? How do you diagnose UTI? How do we diagnose the UTI? Urine analysis and culture. Why do we do culture?
So you know what bacteria?
Very good. So we know exactly what bacteria is in the urine. Now what happened you did UA? You don't know what infection, you don't even know what antibiotic you can give. And patient asks you, my doctor has started me on penicillin. Why not other medication the doctor has started and he only gave me the penicillin. Why? Because when we do culture, your answer would be is your bacteria is sensitive to this medication. So when we send the urine specimen, it tells you the infection. When the lab results come back, you have the medication. There are two sections, and they have resistance and they have sensitivity. On the top, your lab result will read the bacteria. And if bacteria are resistant, so I'll give example. You have vancomycin here, you have sulfur drug here, but here you have penicillin is good, erythromycin. You're not going to take the bacteria is resistance. Which medication do you give them? The bacteria is sensitive. So what is your answer for infection? Your bacteria is sensitive to the infection. See how your questions are? Patients are going to ask you questions in your exam. And in the real world, the same thing. We got to learn how to teach them and how to tell them. So number one, you're collecting a urine specimen. How do you collect a culture specimen? And I will be talking more about urine specimen, but just give me one answer. How do you collect the urine specimen? In and out catheter? Yes, one can be in and out. And catheterized specimen? That's okay. Alert patient. Very good. Clean catch specimen. The word is called clean catch. Clean catch is fine to do for your culture. It says clean specimen. What is it important when we are collecting the urine specimen? Midstream. But what is more important than midstream in your answer?
The early morning, the first urine.
Cleaning. And there may be answer. Tell the patient to pee after they throw the first specimen. And your answer question is collecting midstream urine specimen. What do you instruct patient? One answer, collect in the middle of the stream. That's the good answer. And another answer, tell the patient to wash the perineal area. That is your answer. Why? Infection. They're not, what did I say? If you think the straight answer is there, that may not be your straight answer. So when you're collecting clean catch specimen, what is important? Cleaning, washing, prevent contamination. Your specimen contaminated right there when we did not clean. So remember, I will be talking when I move a little bit on specimen, you will have all kinds of questions. Very simple, but these are the questions you can see. How do we collect is, straight answer is there too in the middle, but your answer look for cleaning and wiping. When you are taking from catheter, Foley catheter, where do you take the specimen? Where do you take it from the Foley catheter? There's a place, yes, you guys, some of you said the word port of the catheter. Remember the port of the catheter. So remember UTI question. There may be questions on prevention of UTI and also your incontinent patient. What did we say? Kegel exercise and bladder training, cleaning front and back. All your specimen, first answer, pay attention anywhere, clean it, and teaching on that. Now I will move on your renal failure. What is in renal failure are your kidneys are bad. And what happened to the patient with renal failure? We talked about few things like yesterday. So let's see, what do you think patient has renal failure? Kidneys are bad, kidneys are shutting down. So what is the word is called when you have less urine output? What is the word is called? Oliguria. What is the word anuria? No urine output. So remember this wording, anuria, oliguria. And now I will just say renal failure. If you have acute, there are two kinds of renal failure, acute and chronic. Now remember, acute patient, when they give you a question, they never had a kidney problem, but they went in renal failure. Which patient? Burn, shock patient. So acute renal failure means they never had a kidney problem. All of a sudden, burn patient. What do you monitor? Shock. Why? Because kidney is also shutting down. You monitor potassium. So what happened, renal failure? Maybe burn patient, maybe cardiac failure, maybe shock patient, and so kidneys are shutting down. And you have 3 stages here on acute renal failure, and you will be monitoring for acute renal failure. I would say highlight first your BUN. What is a normal BUN? I said yesterday, we all should know, creatinine, highlight. And then you have BUN and creatinine goes high. They're not normal. Any question they show high, that means the kidneys are failing. Underline the word oliguric phase. Oliguric phase is all of a sudden kidneys are shutting down and urine output is low. When you have low urine output, what happened to the patient here is your urine output is low, oliguric state. Any question, patient is in oliguric state, monitor urine. What happened? The BUN is high. Creatinine is high. And what is high here? Potassium. I said yesterday, when you don't pee, your potassium level goes high. So potassium is high. Phosphate level is high. Now I said just before we went on break, if phosphate level is high, what would be low? Calcium would be low. So they have low calcium and potassium is very high. Phosphate is high. Calcium is low. BUN and creatinine is high. So everyone, you guys can add few things here. On the side, everyone should know BUN and creatinine. Anytime they're showing more than normal, that means kidneys are bad. Potassium is high, kidneys are bad. Your phosphate level is high, that's why they don't have enough calcium and the risk for fracture. What is diuretic stage? When you stabilize the patient, they start peeing. What is oliguric? Low urine output. Diuretic means urine output is increasing. Everything start getting normalized. Once you start, patients start peeing more, that means all the things are stabilized. Last stage is rehab. That means they are stabilizing and they're doing okay. So everyone, what is renal failure? In another word, we are retaining fluid. Are we clear? Why? Because we are not peeing here. So in your mind, as soon as, just like I said yesterday, what is CHF? Fluid retention. What is renal failure? Another answer may be oliguria, edema, or a lot of word they use preorbital edema, generalized edema. So what does the patient has in renal failure? Everyone is okay, edema. What is the patient is having here? Oliguria. What is high here? Potassium is high. Very simple for this exam. When your potassium is high and your kidneys are not good, you cannot give more potassium to your patient. So check the potassium level. Then I want you highlight that word diuretic and monitor, go under sodium and potassium. And sodium is extracellular and sodium is extra, potassium is intracellular. Then you will go on renal failure is fluid encouragement we have. But what would be the more with the renal failure? Go underneath excessive fluid volume. And skip for now fluid encouragement, but just go fluid volume is high. So what is excessive fluid means? We are retaining fluid. When do we retain fluid? Either you gave too much of fluid to the patient, they're drinking more water, or what else do you did for your patient here is maybe patient has CHF, or what does the patient has? Renal failure. Excessive means they're retaining more fluid. What is the sign I said yesterday? Jugular vein. Neck get distended in CHF patient. Dyspnea is very important. The question is, patient is overfluided or excessive fluid volume. What do you assess? Now we all know the weight, but I also want with the weight to remember the word lungs. So what are we assessing here? The lungs. And underline the word is tachycardia. What is the meaning is here? is edema and pulmonary edema. And patient has all over edema and they are having tachycardia and write down their tachypnea. What do you give them? Position. Position we said yesterday, when you have too much of fluid, semi-Fowler's. Maybe patient need oxygen. What do you assess here? The lung sounds. Make sure we write on the lung sound. Now, so that covers a little bit here. Now, fluid encouragement, let's highlight the word for UTI question. And cleaning from anterior to posterior. Presence of sediment, and make sure you're checking the sediment for the infection. Deficient fluid volume. When you remove all of a sudden fluid, those two wording are very important for your test. For your care plan question, when patient is having dehydration, what would be your care plan wording would be? Deficient fluid volume. Remember the care plan? You guys have done a lot of care plan. And what do you write if your patient has diarrhea? They give you a question. Patient is having diarrhea and vomiting. What would you be making your care plan and what are you monitoring? Deficient fluid volume. Patient is having diarrhea, vomiting, and what would you monitor in deficient fluid volume? Number one, weight is important. Skin turgor is important. On the skin turgor, I want you to write down some question, capillary refill. What is the normal capillary refill is? Less than 3 seconds. Mucous membrane. I want you to write down also depressed fontanelles in the babies. And urine output. What would be the urine when you're dehydrated? Would be more or less? Less. In maybe Pete's question, baby is having diarrhea. Mother brings the baby. What do you ask the first thing from the mother? How many times have you changed the diaper? And so a lot of questions, not all dehydration, mucous membrane. In these days questions, we have different answer. Tachycardia. What is tachycardia? Sign of shock. What is losing fluid? Hypovolemia. So I want you to remind you guys, key wording are very important. Question, fluid dehydration question, renal failure question, CHF, you have too much of fluid. So what do you monitor? Too much of fluid we talked about. And when you have dehydration, these are your wording for your care plan. And what do you monitor? Maybe a capillary refill. Maybe sunken eyes. You will see them. They're dehydrated. So that goes in your dehydration question. Now I will go on chronic renal failure. What is one of the reasons for renal failure are? Chronic renal failure are diseases, hypertension and diabetic patients. So we have been talking about that earlier. So remember, connect your questions. Renal failure can be because of hypertension and diabetic patient. When you have patient with renal failure, or end stage of renal failure, what do we give them on renal failure? Dialysis, very good. And what are the two kinds of dialysis we have? What are the two kinds of dialysis we do? Peritoneal dialysis and hemodialysis. So everyone knows peritoneal dialysis. Peritoneal dialysis. Hemo means when they're going in the dialysis center and they're giving through your shunt. That the hemodialysis patient has shunt. What do you monitor for patient who's going for peritoneal dialysis? What is peritoneal? They can go from the peritoneum right here. Below the umbilicus area, they have a catheter. They can fill the fluid and they can let it drain later on, and they are exchanging. First thing, if they ask you, what is it, why do we do dialysis? Why do we do dialysis? To remove excessive fluid. And what is excessive here? Electrolytes. What is electrolyte? Sodium, potassium, calcium, magnesium. So how do you know your dialysis is working? Your simple answer, your electrolytes will be normal. Are we clear? See how your answers are? I want you to write down on the side. Dialysis you are giving to what? Drained fluids. And removing extra, maintaining electrolytes. And what happened after your patient come back from dialysis? How do we know our dialysis is working? Patient lost fluid and all the electrolytes, potassium was very high. Now your and maybe one answer, potassium would be normal. Are we clear? So write down the word electrolytes. What is very important electrolytes? Your potassium. And you're going to look for phosphate and your calcium. But this is number one. Potassium is very high. When they drain the fluid, potassium level is going to be low. So that is the function of dialysis. Now I will go back, peritoneal dialysis. What is the risk for peritoneal dialysis for our patients are, number one, infection. And what is the word is called? Again, peritonitis. Write down the word peritoneal dialysis, peritonitis. Now if they give you a question and they're saying you have a patient and which patient contraindicated. What is the meaning contraindicated? They cannot go for peritoneal dialysis. Your answer is if they have peritonitis. They already had infection. Or if they're going for abdominal surgery. If they are going for renal transplant. But for now, for your exam, I want everyone know the wording peritonitis. Everyone is okay? Peritonitis, and another word I said is peritoneal dialysis. What is the complication if they're asking? Peritonitis. Which patient is contraindicated? You cannot give peritoneal dialysis if they have peritonitis. Next is hemodialysis question. What is in hemodialysis is, you remember, they have shunt. And we already said, what do we monitor on shunt here? Is you're looking for, you guys have here, is second line dialysis 3 times. And I want you to, in the third line, monitor the thrill and the brute. No blood pressure may be a question. You have CNA and you have a patient with a shunt on the right side and she's taking a blood pressure. You are going to correct her. She cannot take the blood pressure on that side. Are we clear? So you got to read your question on your CNA job. They're doing wrong. You got to correct it. But we must know no blood pressure, no blood, taking out the blood on that side. When do you weigh for what do you do before dialysis? Everyone remember, whether it's a peritoneal or hemo, we must take a patient weight. That shows how much patient is retaining the fluid. So what do we monitor before dialysis? Weight. Then you will underline the word is diet, is low protein, and underline the word after dialysis, you give their medication, BP medication. Check the blood pressure and dialysis patient weigh the before. And what you do not give, highlight the word medication. When your patient is going, especially your hemodialysis, you do not give their medication when they're going for dialysis. What medication? Your blood pressure medication, your cardiac medication, digoxin, your antibiotic. Why? As soon as you give them, they're going in dialysis and they're coming out from the body. It is not going to be effective. I had a patient who the nurses are not holding the medication and patient is going on dialysis, and when they come back, not even back in dialysis, they fell 2-3 times. Why? Because we gave the medication. So remember, as a nurses, doctor is not going to give you all these instructions, what we are learning. This is, we need to learn. Doctor has gave you order to give digoxin morning and give blood pressure medication, but you are sending your patient 3 times for dialysis. Now, before your patient is going, they're taking the patient, maybe transportation company comes and pick up the patient, don't give them medication. When they come back, then you give those medication. Why? Because it's going to be washed out from the blood. When do we check their weight? Before. What do you do after your patient come back from dialysis? Is monitor blood pressure. Weight is important, but blood pressure is very important. Why? Because they have removed the fluid. And what does it cause here? Hypotension. Because they removed the fluid, what is it having? Hypovolemia. And what does the hypovolemia would lead to? Or is the patient blood pressure would be low, patient is very dizzy and they're very weak after this dialysis. And immediately, what do? You tell your CNA when patient return, put them back to bed and check their blood pressure. Why? Because it can cause them a lot of orthostatic hypotension. Everyone is okay? Dialysis question is, when do we check the weight? Before. What is important afterwards? Even weight and blood pressure. Before your patient is going on dialysis, what do we hold here? Their medication, especially their blood pressure medication. So weight, you can add there, and also diet, underline the word protein, and low sodium and low potassium. And we did in the drug Apogen. I talked earlier, Apogen is given. Number 1, they are very anemic patients. Your kidneys are making your red blood cell. In our mind, patient who has renal failure, they are anemic. And what do you prevent them from falling? Because they feel very dizzy, they're weak. And what do you give Apogen to increase the red blood cell? So what medication do we give them? Apogen. Are we okay? So everyone, renal failure, peritoneal dialysis. Let me repeat, peritonitis is important here, and hemodialysis, shunt is important. Before your patient is going out, what do we monitor here? Is the blood pressure. When patient come back, what do you monitor? The weight is important before, and the blood pressure after they come back, because they're feeling very dizzy. So renal failure questions are good. We must know the wording Apogen, anemia word, and all the peritonitis for peritoneal dialysis. I will go on kidney stone. Patient has a stone in the kidney. We all know straining is good. But what else can we do if a patient has a stone? I want you to, and where are the kidneys are? Where are the kidneys? In the back. The word is called retroperitoneal. And write down the word posterior. Posterior means back. Sometimes they don't give the word posterior, and they will use the word retroperitoneal. So remember, when we are talking about kidneys, kidneys are more in the back. And what we are looking for your patients here, for the kidney stones, are strain the urine. And what do we do here? They are giving IV. And a lot of time, Apogen, they give them when they're going for dialysis. And so when you're working like in a long-term care or home, and patient is going dialysis, and they're very expensive medication. You've got to keep them in the fridge. But Apogen is given more in the dialysis center and given through the IV. Are we clear? Iron are slow. They're given PO when your iron is low. But this patient has very low production, and there's not producing enough red blood cell. And that's why we are giving. So I want to move on. Chronic renal failure. Another question was, you have first acute. How do you get chronic? When you are a diabetic, hypertension, maybe repeated, you are having kidneys problem. Maybe acute, many times the kidneys have been affected. Then you run into chronic. Chronic condition, person who is having polycystic kidney disease, diabetic patients, hypertension patients. That means chronic problem are damaging the kidney. When we say end stage means, that means the kidneys are bad. Now patient needs the dialysis. We already talked about dialysis and apogen. I will move on. We already started kidney stone. We talked about staining the urine. And I want you to highlight 2 more words or add there fluid, increased fluid. Ambulation and pain management. Nowadays there's no one word question. The questions are more all that apply. So ambulation is good to help to pass the stone, and increased fluid is also good. Straining is good. Pain medication, there are a lot of pain when the stones are coming out. Pain management. I will go on BPH, is the prostate enlargement, benign prostate enlargement. Where is the prostate gland? Around the urethra. So what happens when the prostate, and which are the patients are common, older age, and the prostate gland is enlarged. And what would be the sign of patient who is having enlarged prostate? What are the signs would you think on your patient would be? Dribbling, incontinency, and they cannot pass the urine in a big stream. Urine comes very low, slow. And nocturnal maturation. They get up in the night time to pee more because they can't empty the bladder. What is the big problem with the enlarged prostate can be? When you don't empty the bladder, again, UTI and urinary sepsis. Whenever urine is staying for longer time, it can lead to septic infection, but number 1, UTI. So everyone we know is a problem in not is making a urine, but taking out, because it's circling the urethra, and the maturation problem, emptying the urine. Now what is the treatment are? There are some medication they give them so they can pee, but the surgery is done. And underline the word TURP. Everyone remember with the TURP questions are, what is TURP is? Transurethral resection of prostate gland. TURP, you will see for patient with prostate enlargement. The full word is transurethral resection of prostate gland. That means they're removing the prostate gland through the urethra. Transurethral resection of the prostate gland. Everyone remember the risk of TURP. Whenever you see this question, is a patient come back after TURP, what do you monitor patient here? Bleeding. Everyone should know bleeding. When I'm going in catheter, maybe I will see the word 3-way catheter. What is the meaning 3-way catheter? Foley catheter at the end has 2. And 1 you attach for the urine and 1 to inflate the bulb. But this catheter has 3 sections at the end. What one is for draining the urine, and second is for continuous irrigation, and third part is to inflate the bulb. Now, very important that you know the wording TURP. They remove the prostate gland. Patient remove the prostate gland, coming back. What kind of catheter patient has in your question? And your answer is what? 3-way catheter. What is 3 section at the end? 1 you're attaching for the urine bag is draining urine. Second one, we are going to give irrigation. Water is going inside and coming out through the catheter. So what is called continuous irrigation. And what is the meaning continuous irrigation? You're washing out the bladder. But why? To stop the bleeding. So what is the risk of this surgery is that everyone should know bleeding. And that's why doctor knows they're going to bleed. They already put the catheter, is called 3-way catheter. Why do we have 3-way catheter? To do continuous irrigation. Everyone is okay? Continuous irrigation is given. So you're not doing with the syringe. We have a big bag of normal saline and we hang it just like IV and it goes straight all the time in the bladder and it comes out and washing the bladder. Everyone is okay? What is continuous? When we do one-time irrigation, we are taking a syringe and we take normal saline and we wash it, we flush it. That's called flushing or irrigation. But when we are saying continuous mean, the continuous water is going inside the bladder and is washing out the bladder. So everyone TURP is done surgery for prostate gland. Everyone should know what do you monitor when patient come back after the surgery is the bleeding. And what would be the patient would have here? 3-way catheter. Maybe a question. Patient has TURP and patient come back and patient is bleeding. What do you do? Patient has a lot of clots and fresh blood is coming out. Answer may be call the doctor, notify RN, or start irrigation. Your answer is start irrigation. They're checking whether you know patient has irrigation order. Doctor has already sent you the order for irrigation. Doctor has already put it in the patient with 3-way catheter. Everyone is all right? So what do you start here? Irrigation. Why? To clean the bladder and preventing the clotting and washing out the bladder. So this is called 3-way catheter. TURP, you're monitoring bleeding. What are you doing in TURP? Another question. Doctor has ordered continuous bladder irrigation. What do you monitor when you give bladder irrigation? What is our next word we said for ICP is very important, water intoxication. Every word, we got to connect it together. So what are you doing when you are pushing too much of water in the bladder? It can cause what? I want you to write down the word water intoxication. In your question, any question, you have the word water intoxication. What are we monitoring with water intoxication? ICP. What is water intoxication? Cerebral edema. Too much of fluid. Your body is not absorbing. And what is it leading here? Cerebral edema. So any question whenever you give too much of fluid, what happened? You're going in water intoxication. And that intoxication also comes patient with hemodialysis. When we learn more in details, one of the complications of hemodialysis is water intoxication. Why? Because they're washing out with a lot of water and patient, and maybe question, patient is during dialysis and patient change level of consciousness, patient start vomiting and patient has bradycardia, sign of ICP. So where do you get water intoxication work? When your body cannot absorb that fluid and it lead to too much of fluid in the body and leading into ICP. Which patient, we said yesterday we are monitoring ICP, you guys were good, you said bleeding, stroke patient you're monitoring, now you add in your question, water intoxication. Everyone is okay. Another question, patient is admitted, patient was home and patient says he has taken enema, but he has taken 3 liters of fluid and he is feeling sick, he's feeling dizziness, his blood pressure is changing, his vital signs are changing, he's vomiting. What are the signs here again? Too much of water, water intoxication. Everyone is okay, water intoxication lead to what? ICP. What is water intoxication? Cerebral edema. Patient has prostate gland removed. What are we monitoring? TURP questions are, is number 1 is bleeding. What is bleeding is because they're through the surgery is a risk for bleeding, and that's why patient is coming back with what catheter? 3-way catheter. What is 3-way catheter? Is given for continuous irrigation. And one side the urine is coming out, so the water is going continuously. And if they give you a question, another question. See, I'm not doing a whole lot of theory, but I'm connecting you what you should have been known by now. And sometimes you are done and you may not connect it, but it's very important that we know. Now, if they give you a question, your urine bag, and you have emptied the bag, and there's a 900 cc in your time when you are giving continuous bladder irrigation. What is your, and another question maybe on that, your urine output is this, and irrigation solution you have used is 200 cc. What is your total output? You got to minus the fluid you're putting in the bladder. Are we clear? What is continuous irrigation? The fluid is going in the bladder. So when it's coming out with the urine, that fluid is coming out through that catheter. So when you empty the urine bag, it's a 900 cc. And this is the type of question they love to give. And this is very high in NCLEX question. So what do you monitor here? You empty. There is a 900. How much solution you used it in your time? 200. So what do we do here? Minus 200. So what is your output is? 700. So don't write in your output 900. What amount you will write in your output is 700. For your exam, everyone remember, any irrigation we are giving, whatever the fluid come back, you got to minus it from your total fluid. In irrigation question, continuous irrigation, we use the word CBI, continuous bladder irrigation. What is continuous bladder irrigation? We are monitoring water intoxication, number one. In the urine output, you minus the irrigant solution. Sometimes they use the word irrigant, sometimes they didn't give complete irrigation solution. So irrigant means you're washing the bladder. What is the purpose of washing the bladder here? To stop the bleeding. And how long do you continue this? Patient says, how long I'm going to lay in bed? How long are you going to do this irrigation for me? Your answer would be until the urine comes clear or light pink color. What does it mean? The bleeding has stopped. Are we clear? See how the wording are? So that's very important, and I wanted to add that in BPH. Everyone is okay. Third word, everyone, continuous bladder irrigation and water intoxication. Let me move into now endocrine system. In endocrine system, you guys have hyperthyroid. So let's finish hyper. And we talked about hypo, and I may add a few lines here. But let's do hyperthyroid. What is hyperthyroid is called, underline the word grave disease. They're losing weight. They have palpitation. Underline the word nervousness, diarrhea, exophthalmos, bulging eyes. What medication do you give? I want you to write down anti-thyroid medication. Now when they give you the word and they're saying what is anti-thyroid, that means they have already too much of hormone and you are stopping too much of hormone. So what medications we are giving here? Anti-thyroid medication. What is anti-thyroid medication? Given for hyperthyroid. What are the medications are here? Second line, PTU, prothyrosil and tapazole. And also, I said yesterday, same medication you can use for thyroid storm. Are we clear? And what is surgical treatment? We said thyroidectomy. And I said yesterday is oxygen and suction, and tracheostomy tube is important. What doctor would order to prevent low calcium? Underline the word calcium gluconate. Why does the doctor has ordered calcium gluconate? Because they're going to lose calcium. And so calcium gluconate is given why? Underline the word to prevent hypocalcemia, or write down the word tetany on the top. Sometimes they don't give hypocalcemia and to prevent tetany. Tetany is twitching of the muscle. Now we underline, so we all know what is hyperthyroid. They have too much of hormones. Thyroidectomy, patient come back, thyroidectomy. We said tracheostomy is good, oxygen we said is good, and also calcium gluconate you have in hyperthyroid. Now positive sign, that means patient has low calcium. How do we know positive sign? Underline the word chovastic sign. That goes on face, underline that. Trouser sign, I underline the word carpal spasm. You must know what spasm, carpal spasm, when you're putting the blood pressure cuff. So everyone is okay, thyroidectomy, immediately problem are, I want you to add there, you already know, is they can go thyroid storm, low calcium, and I want you to write down the word is the laryngeal stridor. Whenever you see the word stridor, they cannot breathe. Severe breathing problem, stridor. And low calcium, and we all know where do we get the calcium. Now I want you to move on, is hypothyroid. Hypo is myxedema. And also you will go on congenital. In congenital, it is called cretinism in the babies. What is the sign of cretinism in the babies is they're very slow, and cretinism lead to mental retardation. The mother says, my baby is very slow. When I'm giving feeding, baby is sleeping. That means the baby is having what? Cretinism. They're very slow, quieter, but it leads to mental retardation. Now, hypothyroid patient myxedema, sign are, what is low here? T3, T4. And what are the signs here? Bradycardia, hypotension. They gain weight. Hypo gain weight, hyper lose weight. They are cold. Hyper are warm. And constipation. And underline the word thyroid hormone. I said yesterday, what is thyroid hormone is synthroid. And what is the best time you give synthroid early in the morning. So we finished thyroid gland. I will move on, adrenal gland. In adrenal gland, we said few things yesterday, but I want you to remember adrenal gland. What are the adrenal glands? Are on the top of the kidneys. So we have two adrenal glands. Adrenal gland is very important is, if you keep two words in mind, your adrenal gland is producing your steroids. And second thing is, you remember the wording I said yesterday, glucocorticoid, when we were doing the drugs, and mineral corticoid. There are two wording you have to know for exam. Mineral corticoid, glucocorticoid. When they're saying patient is ordered glucocorticoid, that means they're giving steroids. But what is Cushing is here. They have too much of a steroid. So I'm going to write Cushing on one side, and you guys can highlight the word. They have too much of steroid. What part of the gland is adrenal cortex? So I want to make sure you know Cushing and Addison, adrenal cortex. There are two parts of the adrenal gland, medulla and the cortex. So what is the part here is the cortex, too much of steroids, and they have too much of glucocorticoid and mineral corticoid. And I said yesterday the risk for, underline the word, infection. What isolation do we put them here? Reverse isolation. So write down on the side, reverse isolation. And any purulent secretion, that means infection. Patient is taking steroid, a patient is Cushing, and they're having a purulent. Purulent means infection. Next is monitor the weight gain. So Cushing patients are gaining weight. And number two, prevent them from infection. And what are we putting them in? Reverse isolation. Next one, I want you to underline the word administered insulin. So I'm going to say here, Cushing patient has too much of sodium, too much of sugar, and blood pressure is high. What is low here is potassium and calcium. Yesterday I said when you are giving any patient your steroid or Cushing, what they are having here, too much of sugar. Are you going to monitor hyperglycemia? Yes. So what do you monitor? Underline the word insulin. It says sugar is high. Osteoporosis. And in the next line it says bleeding. But what do you have here? Hypertension. What I wrote it here. Hypertension. Hyperglycemia means sugar is high. Hypernatremia means sodium is high. And what is low here? Potassium. And what is low here? Calcium. You write down with the calcium, what do you do to prevent them from fractures? Are we clear? So sugar is high. What do you need to give insulin? Calcium is low. You're preventing them from fractures. All right. So a little bit idea for you guys, Cushing. Cushing is what? Adrenal gland, too much of steroid. Too much of steroids, you have to monitor your patient as you have on your patient with too much of steroids or you are giving steroids. Next is Addison. Addison is low steroids. So they have no steroids or very low steroids and you're going to give them steroid. What is low here? Sodium. What is low here? Sugar. What is low here? Blood pressure. What is high here? Potassium and calcium. These two are opposite, not hard to recognize. And Addison patient, what drug do you give them? Yesterday we said mineral corticoid. So maybe you're giving steroid, mineral corticoid, and Florina. And their skin is very pigmented. And they're losing weight. Cushing is gaining weight, they're losing weight. And you're giving steroid, you monitor, you're turning them into Cushing. It's opposite. So what is in Cushing R is too much of steroids. What is Addison R? Too less steroids. So if you will remember some part there, remember the word glucocorticoid and mineral corticoid. That would be enough, prevent them from infection. Isolation question can be there. Monitoring sugar level is important and the fractures. I will move on your diabetes because it's pancreas gland. What is pancreas is producing our insulin. Patients who are diabetic are problem in digestion of protein, carb, and fat. We all think a lot of time is the sugar. But what about carb? You eat more carb, your sugar is going to be up. So what is the problem in diabetic patient is digestion or affect the protein, carb, and fat metabolism. Hypoglycemia sign, we all should know, is headache, I have it here, nausea, sweating, very important, tremor. When we say hypo means they're shaking. Tremor, because low sugar. And tingling around the mouth. Confusion, low sugar. And monitor patient for consciousness, check. And what do? If patient can swallow, you can give them carb. What carb you will take? Complex carb. And also milk has sugar. Graham crackers. Peanut butter, good. Orange juice is good. Glucose, you can give them. Dextrose. Now, if patient cannot swallow, at the last word, it says, it's a glucagon. Glucagon. The spelling is not correct. If your patient cannot swallow, and you cannot give them any oral juice, then what do you have to do? Give them glucagon. Or what can you give? IV dextrose. That's what happens when you have ambulance comes in. Any patient hypoglycemia, first thing they start IV dextrose. IV dextrose means IV sugar you're giving. Dextrose is glucose you can give them. So hypoglycemia, low sugar, monitor your patient blood sugar, and immediately after you give something, recheck the blood sugar in 30 minutes. Hyperglycemia. Hyperglycemia means too much of sugar. What is hyperglycemia? Signs are polyuria, polydipsia, polyphagia, and vision, affecting blurry vision. When the sugar goes up, persons start feeling vision problem. They get up in the nighttime, they feel fatigue, and also they feel cramping. Now, feet during in the experience is usually when hyperglycemia, they feel hot. But the extremity, they may feel cold, but usually they feel hot. And then you go tingling in the lower part. Whenever you are a patient who is diabetic and their sugar is high, their problem in wound healing. Diabetic patient wound healing is a problem. And how does the sugar goes high? What are the reasons for patient sugar is not controlling? Number one, stress. When you have a stress, we all know when you eat more sugar or food, your sugar is going to be high. But without the food, a stress and infection. Any infection you get in the body that will increase your hyperglycemia. Your sugar is not going to be under control. And if you are diabetic and you are taking steroids, your sugar is going to be more higher. So remember, your questions are not straight. What is diabetic? Maybe patient is having a stress. Patient is going for surgery. Their sugar level is going to be high. We already talked about glycosylated hemoglobin blood test, and 4 to 6 is normal. More than 6% is going to be high. 30 to 120 days you do the blood sugar, and high means they're not controlling their sugar. Insulin, we talked about it, regular insulin. You can give them rapid acting insulin, we talked about that, and the tray, we talked about those things. Now, and remember, we already talked about hyperparathyroid, but I want you to add on the side or anywhere 2 things here. Do not mix and how you will see. When your patient has hypoparathyroid, I want you to remember your calcium level is low, phosphorus is high, and you are monitoring for muscles, monitoring for tetany, laryngeal stridor, seizure they're going into. Lot of low calcium can lead depression. So remember, very important, don't forget tetany, don't forget laryngeal stridor. Sometimes monitor for seizure. Now I will go on hyperparathyroid. Hyperparathyroid means is they have too much of calcium in the blood. And what is low here? Phosphorus. Just write down a little bit 2 words. How you connect your question. When you are giving hyperparathyroid, too much of calcium is floating in the blood, and they are not absorbing in the bones. And here, you write down the word osteoporosis. Number 1, and number 2, too much of calcium causes renal stone. Okay? Yes, all low calcium can lead to osteoporosis. Immediately your question. And I just said when you have very low calcium, you can give them calcium gluconate IV. All right. So hyperparathyroid means is what? Too much of calcium. And what does too much of calcium lead to? Renal stone. And because this calcium is in the blood and they are not absorbing in the bones, what does it lead to? Pathological fracture. That means the bones are weak. Everyone is okay to answer? Why? Because your calcium is not going towards the bone. It's just floating in the blood. So you have to give those patients medication to get better absorption. Hypoparathyroid, your gland is not producing when your questions are. That means you monitor tetany, laryngeal stridor, and seizure, very important. If you don't have, they have osteoporosis, okay, go for that. But hyperparathyroid means is they have too much of calcium. Don't increase calcium for these patients because they are already having too much of calcium. So just to have a little bit difference here, I don't want you to mixing up any question. But yes, calcium question is very high. Parathyroid questions in all the exams are very important, we know. So we have done pretty much some of important endocrine system part. I will move on a little bit on respiratory area. In breathing problem, and in breathing questions are oxygen, pulmonary embolism, COPD question can be. So let's highlight here for you guys on respiratory. You have all your patient, pre-op patient, coming back after surgery. What do you teach them pre-op patients are to prevent pneumonia? in the second line, PNA word, it says there, pneumonia. What do you teach your patient to prevent pneumonia? Deep breathing exercise. And what do we give them after they come back after surgery? Remember the word incentive spirometer. What is incentive spirometer? For breathing exercise. So prevent pneumonia by turning, deep breathing exercise for your patient who's having a breathing problem. Next is, I want to talk few lines here, pneumonia, and I want you to add there about pneumonia. How do you prevent pneumonia also? We said is deep breathing exercise. Any other thing? Pneumonia. That's a breathing, yes, chest physiotherapy. But what is other reason? How can you prevent pneumonia? Pneumonia is nosocomial infection.
Lots of fluid. Oh, vaccination.
Where, that's what I wanted to hear, is pneumovaccination. Somebody said it here. So write down the word pneumovax. Very important. Who do we give pneumovax? Older patient and chronic patient. So who you are giving pneumovax here? Older patient. And maybe your question, and chronic patients must get their pneumovax. So how do you prevent pneumonia? For weather comes in, older people are very risk to get pneumonia. So write down the word pneumovax, and you give them to who? Older population and chronic, meaning somebody who has asthma, diabetic, the chronic patient. And what happened to the chronic patient? The resistance is very low and they can get infection. So number one, all your questions are prevention. So everyone remember pneumovax is number one. And pneumonia is nosocomial. We have to prevent them by turning, incentive spirometer, and chest physiotherapy. And what do you monitor if you have a patient with pneumonia? What are the problem with pneumonia is? What are the sign and symptom do you see in a patient? Fever, very good. Infection, very good. Yes, you guys are good. Come on, fever. And what else would be with pneumonia? Respiration, excellent. What is the problem with respiration? Tachycardia. Lungs are congested and they cannot breathe. I can hear now. I think it's there. If you guys need to take a break quickly, go ahead. But till we clean it